Hello friends, today we are going to discuss about neuropsychiatric aspects of epilepsy. I am Dr. Suresh Badadmat, Professor of Psychiatry working at NIMANS, Bangalore. In this video, I'll be discussing about the neuropsychiatric aspects of epilepsy, the classification, etiology, prevalence, assessment, and management. Before we start, let's define what is meant by seizures and also epilepsy. Seizures means it is a sudden onset of uncontrolled electrical disturbances in the brain, which can cause changes in the behavior, movement, feelings, and even at the level of consciousness. There are many reasons for seizures, from metabolic encephalopathy to infection in the brain. Then, what is epilepsy? Epilepsy is defined as two unprovoked seizures occurring more than 24 hours apart. So, seizure is 1 or 2 episodes, whereas epilepsy means at least 2 episodes 24 hours apart. Epilepsy is one of the most common serious brain condition affecting 70 million population across the worldwide. Its incidence is bimodal in distribution. The first peak occurs at the age of pediatric, and the second age peak is at the geriatric. Epilepsy is a symptom complex with multiple risk factors and with a strong genetic predisposition. If you look at the causes of epilepsy, you can see there. First and the foremost is a structural cause, if there is a head injury, or else if there is any infection, genetic predisposition, metabolic causes, immune mediated, and many a time we may not be able to know what is the cause. So, there are many causes for the development of epilepsy. And also, it can be classified based upon the onset, whether the onset is focal, generalized. Many a time, the patient comes alone and he is unable to describe the seizure. That time, you have to consider onset is unknown. And also, based upon it can be focal, generalized, it can be focal becoming generalized, or else the semiology we are unable to classify. So, if you are able to get 2 seizures in a 24 hours apart, then you need to consider it as an epilepsy. Approximately 75% of the active epilepsy are untreated, and this causes a major treatment gap. Imagine, out of 100 patients who are suffering from epilepsy, 75 are untreated. That means they are not getting medication. They are having seizures in any place. The main reason for access for treatment is a problem, stigma, discrimination. Further, it adds to morbidity and mortality. Hence, many a time, patients and their family members do not come for treatment. Here, the stigma and discrimination plays a crucial role. Further, presence of comorbid psychiatric condition, maybe post-ictal psychosis or inter-ictal psychosis, will add double discrimination and also adds for the existing burden, poor quality of life, and social outcast. That means many people do not want to touch them also because they believe epilepsy is a transmissible disease. Unfortunate. And if you look at the psychiatric comorbidity in epilepsy, there are many studies which clearly said that up to 30 to 50% of the people newly diagnosed with epilepsy and 50 to 70% of the people with pharmacoresistant epilepsy experience psychiatric and behavioral problems. That means epilepsy and comorbid psychiatric condition has a bidirectional involvement. That means the patient with epilepsy has higher psychiatric comorbidity. At the same time, if the patient has psychiatric illness as a primary diagnosis, there is high possibility he may also develop epilepsy. That means the comorbidity is bidirectional when a person has epilepsy and psychiatric disorder. Let's understand what are the causes. Although I had touched upon, here I will be discussing in detail. First and the foremost is biological in nature. That means there is a shared common etiology between psychiatric illness and epilepsy. If you look at the understanding about EEG, Ictal and inter-ictal neuronal discharges can play a crucial role in the development of psychiatric illness or else the remission of psychiatric illness. If there is a sleep disruption, high possibility the person may develop seizures or else he may develop irritability. Organic or traumatic brain injury is also known to cause both epilepsy and psychiatric illness. Depending upon the type of epilepsy, psychiatric comorbidity increases. Especially complex partial seizure has higher psychiatric morbidity. Further, depending upon the treatment response, if the person has a poor response for epilepsy on antiepileptic medication, there is a high possibility he may not respond, and also there is high possibility he may develop psychiatric illness. Further, because of the stigma and discrimination, there are psychological issues, especially with persons with epilepsy. Social factors such as economic, access to treatment, bodily injuries, economic reasons, and also availability of antiepileptic medicines play a crucial role. Further, side effects of these antiepileptic medications also play a crucial role, especially a young lady who has epilepsy. If she has to take medication, she is bothered or she is worrying about antiepileptic medicine and pregnancy and those medicines causing harm to the newborn. Further, because of epilepsy, many of these patients do not get a job. Even if they get a job, the employer would like to send them away because they are scared. Imagine if a person has an epilepsy and develops injury in the workplace. There is a stigma not only for the patient but also to the employer. Further, the experience of intense social stigma also plays a crucial role in the development of depression or other psychiatric comorbidity. This is the best way to explain the neuropsychiatric aspects and causes. There is an interlink between the neurological causes, the biological underpinning, genetic predisposition, further environmental factors such as social causes, stigma, discrimination, the type of epilepsy, infection, and also if there is autoimmune disease. All these play a crucial role in the development of neuropsychiatric illness. Let's understand and classify the neuropsychiatric aspects of epilepsy. Till now, I have mentioned epilepsy and psychiatric disorder. They are interrelated, and also there is a reverse comorbidity between both. Let's classify the neuropsychiatric aspects of epilepsy. First and the foremost, epilepsy mimicking psychiatric illness. That is, you need to differentiate between what is epilepsy and what is psychiatric disorder. Second one, psychiatric illness arising directly out of epilepsy. That is, post-ictal psychosis and inter-ictal psychosis. Further, if the patient has uncontrolled epilepsy, there is a possibility of epileptic personality change, cognitive dysfunction, and sometimes dementia-like picture which occurs in uncontrolled seizures. Further, the third important is comorbid psychiatric illness with epilepsy. Fourth, epileptic drug-induced behavioral problems. And finally, secondary epilepsy, that is because of infection and autoimmune disease. Please remember these 5 classification of neuropsychiatric aspect of epilepsy. First one is epilepsy mimicking a psychiatric illness, psychiatric illness arising out of epilepsy, comorbid psychiatric illness with epilepsy, epileptic drug-induced behavioral problems, and finally, secondary epilepsy, that is because of infective, autoimmune, or head injury. This classification is for your understanding, easy to classify, and easy to remember. If you look at this seizure, here you can see the patient may have prodrome from 10 minutes to period of 1 to 2 days. And then there is an aura and seizure. After the seizure, the person will have post-ictal confusion state. Based upon this semiology, let's classify this neuropsychiatric aspects. The first one, epilepsy mimicking psychiatric illness. That is the first one. Here, the prodrome. In prodrome, there are many psychiatric illness can be there, and this prodrome can mimic those psychiatric illness. Prodromes are characterized by a broad spectrum of pre-ictal symptoms that may be experienced for a duration of between 10 minutes to several days, which shall persist until the seizure onset. So, what are these prodrome symptoms? There was a systematic review of 8 studies which was conducted by Besk and Vasey. There, they clearly documented what are those prodrome symptoms. Those prodrome symptoms which were commonly seen are funny feeling, confusion, anxiety, which is like a panic attacks, irritability, sometimes speech disturbance, slurring of speech, nausea, anger outburst, and behavioral changes are seen. Here the patient says, over a period of time, yes, I'm able to understand or able to predict when I'm going to get epilepsy. The commonest was, I mentioned, funny feeling, confusion, anxiety, irritability. Many a time, you may consider them as a generalized anxiety disorder or else anxiety disorder in voice. They usually mimic the psychiatric illness. So, prodrome is one possibility. The second one, aura. Aura is basically a breeze or a software as per Latin. Epileptic aura are usually short, lasting for a few seconds to a few minutes. Epileptic auras are typically conceived of as a sign of a focal seizure onset, but well circumscribed. That means they are very brief and they are the onset of focal seizures. The patient is able to perceive them and they are very circumscribed. The incidence of aura ranges from 25% to 60%. It is based upon the epilepsy, the way we ask question, and the assessment type. What are the different types of aura which presents like psychiatric illness? First and the foremost is auditory hallucination in the form of elementary hallucination, visual hallucination in the form of flashlights, olfactory hallucination in the form of pleasant or unpleasant odor, gustatory hallucination in the form of pleasant or unpleasant taste, somatosensory hallucination or else feeling of various touching sensation, sinking feeling, fear, panic attacks, anxiety symptoms, deja vu. Sometimes here the patient feels everything is familiar in unfamiliar surroundings. Yamaisu, in a familiar surroundings, he feels everything is unfamiliar. Some patients may have forced thinking, similar to thought alienation phenomena. Here, the patient feels that somebody is inserting a thoughts into his mind. And very rarely emotional aura. Either the patient may suddenly become depressed or else excited. Moving to the third important, that is seizures. Here again, the ictal phase, there are many seizures which mimic psychiatric illness. First and the foremost is temporal lobe epilepsy, also called as complex partial seizures. Here, in a non-convulsive status also can be seen. In such a scenario, the patient may have macropsia, micropsia. That means the normal objects is seen bigger in macropsia. Micropsia, it is seen smaller than the usual size of the object. Rarely the patient may have automatism, repetitive hand movements, complex activities moving in a circle, or else rubbing things, or else lip smacking. Rarely they may have gustatory and olfactory hallucinations, delusions, illusions. The patients will be seen confused, agitated, and sometimes violence. The second important ictal phenomena which presents as a psychiatric illness, frontal lobe epilepsy. Here the patient will have repetitive hand movements, eye movements to one side, unresponsiveness, difficulty in speaking, sometimes explosive screaming, abnormal body posture, repetitive movements, and sometimes automatism is also seen. Very rarely there is epileptic furor. Furor means sudden onset of violence. Here the patient in ictal phase will have sudden outburst of rage or excitement, during which there is an irrational act of violence may be committed. Here the patient will commit a crime in an undirected fashion or a non-goal directed violence. He will assault the public at large without hurting or without in a goal directed fashion will not be there. In a rare case of epilepsy in such a phenomena, the occurrence of furor takes place and they may be associated with the tonic-clonic or else complex partial seizure or else even without a seizure it can happen. This is known as epileptic furor. And another important is cursive epilepsy. Here is involves running in paroxysms. Here the patient will suddenly start running without any goal-directed activity. there are some very rare epilepsy, it is more of interesting. Orgasmoepilepsy. Here, the patient experiences orgasm as an aura or ictal phase. Gelastic epilepsy. Here, paroxysms of laughing, giggling, and is associated with extreme pleasure. Here, if the patient has gelastic epilepsy, they will refuse to take medication because it is highly pleasurable to have this epilepsy. And dacrocytic epilepsy, it is involving of episodes of crying whenever they develop this phenomena. Moving to the last part, that is post-ictal confusion state. Here in post-ictal confusion state, the psychiatric presentation is very common. Usually, the post-ictal phase lasts for 10 to 15 minutes, which is associated with maybe confusion, disorientation, sometimes shouting. But when it becomes prolonged, maybe associated with substance use, metabolic encephalopathy, head injury, bodily injury, that means at that time, the disorientation and confusion lasts for many days, many hours. And sometimes you can see agitation, irritability, violence, altered sleep, and doing some complex activity which they may not remember. Moving to the second part of our discussion, that is psychiatric illness arising out of epilepsy. That means there are epilepsies occurring. Now there is suddenly some psychiatric illness appears. First and the foremost is the post-ictal psychosis. That means here the very important thing is the epilepsy has occurred, but there is a normalcy period. That means after the epilepsy, there was a post-confusional state. He got up, he is fine for a period of 2 to 3 hours, and then he develops post-ictal psychosis. That means there should be a lucid interval. Let's look at the diagnostic criteria. Loxdale and Tones have given a criteria for post-ictal psychosis. Let's look into this criteria. First and the foremost, psychosis developing within 1 week of a seizure, or there is a cluster of seizures. Here, the psychosis lasts for 15 hours to 2 months. Here, the phenomenology should occur in a clear consciousness. That means there should not be any disorientation. As I mentioned, there should be some time lucid interval is required. The patient will have clear-cut delusions in the form of paranoid, non-paranoid delusions, delusion of misidentification, grandiose delusions. Sometimes religious delusions are also seen. Hallucination is in the form of auditory hallucination, visual hallucination, and olfactory hallucinations. But however, there should be some exclusion criteria has been mentioned. Here, during this post-ictal psychosis, there should not be any seizure activity. That means there should not be evidence of any seizure activity on EEG. Antiepileptic drug toxicity should not be there. There should not be any head trauma, or alcohol or drug abuse or withdrawal should not occur. That is a very essential criteria for post-ictal psychosis. Here, as I mentioned, the lucid interval after the cessation of seizures, there is a post-ictal confusion state and there should be a lucid interval, maybe 4 hours to 1 week. And here, the very important thing is fluctuating combination of thought disorder should be there. That means there should be like a acute polymorphic psychosis along with auditory and visual hallucination. Delusions, as I mentioned, the classically in post-ictal psychosis is grandiose, religious, and persecutory delusions are commonly seen. The religious delusion is the hallmark of post-ictal psychosis. Here the patient feels that he is a god, he will have increased religious activity. At the same time, he also will have delusion of persecution, reference, violence, mood symptoms also will be seen. That means he may have manic symptoms or depressive symptoms, at time aggression. So you have to understand this post-ictal psychosis is a combination of psychotic symptoms and also mood symptoms. And the post-ictal psychosis, what are the risk factors? That means who are going to develop the post-ictal psychosis? First and the foremost, if he has intellectual dysfunction, that means mental retardation or mental disability, substance use if it is there, family history of psychosis is there and also is having epilepsy, complex partial seizure, long-standing epilepsy, and cluster of attacks if it is there, then there is a high possibility he may develop post-ictal psychosis. Now, till now we discussed about post-ictal psychosis. What is inter-ictal psychosis? If the psychosis occurs in between a seizure, that means the psychosis is unrelated to seizure episodes. You may have seizure or you may not have seizure, but the psychosis is there. It is unrelated to seizure. That is inter-ictal psychosis. That means if a person had epilepsy and after 1 or 2 months down the line, he may have a psychosis and he may not have epilepsy immediately. He may have epilepsy after 1 year. That means, as I showed here in the diagram, here there is an inter-ictal psychosis and the seizure episodes are wide apart. There is a phenomenon called as forced normalization. What does it mean? Whenever there is a seizure, then the person will not have psychosis. But whenever the seizure stops, he will have psychosis. That means there is an inverse relationship between EEG and psychosis. Also, it can be easily considered as antagonistic relationship between psychosis and seizures. As I see here, there is a seizure and there is no psychosis. And when there is psychosis, there will be no seizure. This is a clear depiction. That means there is a seizure and you can see EEG changes. After that, he is fine. There is no EEG changes, but he develops psychosis. And later he develops a seizure and psychosis vanishes. That is forced normalization. What do you mean by forced normalization? Forced normalization was given by Hendrik Landlot. That is in 1953. This forced normalization is an electrophysiological phenomena. That is electroencephalogram phenomena in which emergence of psychiatric symptoms on electrical stabilization of EEG. That means whenever the EEG is normal, the patient develops psychosis. As soon as he develops seizure, psychosis stops. And another important term came is alternative psychosis, also called as reciprocal psychosis. This was coined by Tullenbach. This is similar to forced normalization, but in forced normalization, it is a phenomena observed in EEG, whereas in alternative psychosis or reciprocal psychosis, it is a clinical phenomena where a patient's observable seizure is seen and then there is a remission of psychosis. And whenever there is a psychosis, there is no seizures. That clinical phenomena is called as alternative psychosis or reciprocal psychosis. Further, there is something called as paradoxical normalization. This was coined by Wolf in 1991, which describes epilepsy is there and active, but it is subcortical. You need to have special EEG method like sphenoidal EEG to capture this. That means the patient has psychosis and may also have subcortical EEG changes. That is called as paradoxical normalization. If you look at the meta-analysis, here the prevalence of psychosis in epilepsy, especially a systematic review and a meta-analysis was conducted. This is a very important study and you need to read this study. This meta-analysis included 58 articles to assess the prevalence of psychosis in persons with epilepsy. And this study summarized, telling that 6% of persons with epilepsy had comorbid psychotic illness. In general population, it is less than 1%. In epileptic population, it is 6%. That means there is a 6-time increased chances of developing psychosis in persons with epilepsy. Further, the meta-analysis also calculated what is the prevalence of psychosis in temporal lobe epilepsy. It was very high. It is 7%. And they also found inter-ictal psychosis was around 5% and post-ictal psychosis was 2%. Post-ictal psychosis means, as I mentioned, invariably it is immediately after the seizure. So it is very less. Let's look into the important phenomena, epileptic personality change. Epileptic personality change is also called as Gestalt-Gustavich syndrome, and it is commonly seen as uncontrolled temporal lobe epilepsy. What is the classical presentation of this Gestalt-Gustavich syndrome? First and the foremost is irritability, stubbornness, altered sexual behavior, circumstantiality. The person will not come to the point very easily. He will give unwanted, trivial issues where the examiner becomes very irritated. Circumstantiality, hyper-religiosity, hypergraphia, pseudo-philosophical thinking, viscosity. That means he's very sticky. But the classical will be hypergraphia. Here the person will write in length many pages, but it will convey very less. So these are a classical presentation of epileptic personality change. Now, once we have discussed about this, we will discuss about cognitive deficits of epilepsy. The risk factors for developing cognitive impairment. There are commonly seen in childhood onset of epilepsy. And what is the age of onset? Earlier the age of onset, repeated high frequency of seizures, intractable seizures, difficult to treat. If the duration of epilepsy is long standing, depending upon the type of epilepsy, whether the choice of drug compliance, comorbid conditions, whereas less especially seen in children, such as Elke syndrome, Dravet syndrome, Benign-Rolandic syndrome, epilepsy, and also Lennox-Gastaut syndrome. So if these syndromes are there, there is a high possibility the cognitive impairment will occur. The cognitive deficits in epilepsy is commonly seen in children. How does it manifest? Whenever a child has a seizures, invariably they will be having a loss of milestones. What are those? Whatever they are recently gained. It may be associated with decreased attention and concentration. If the child has developed a learning ability or speaking, he may develop aphasia, memory loss, difficulty in language, and many other. Many a time it also you can see the child will start having bedwetting. Already he had developed the bladder control, he may lose after epilepsy. Adult with epilepsy also will have cognitive impairment, which is largely dependent on the area of epileptogenetics. That means wherever the epilepsy occurs, that means it is epileptogenic focus of the brain. If the person has the epileptogenesis is in the temporal lobe, the memory disturbance is seen. If it is in the frontal lobe, behavioral abnormalities will be seen, impulsivity will be seen, changes in personality will be seen. And again, this is the very classical presentation. But however, cognitive deficits are very well in a prolonged uncontrolled seizures, sometimes may lead to dementia like picture in the long run. Now moving to the third important point, that is comorbid psychiatric illness with epilepsy. What are these comorbid psychiatric illness? That means the epilepsy is there. Along with that, he may develop another psychiatric illness, but they are very difficult to have the relationship between direct one-to-one with the epilepsy. For example, is generalized anxiety disorder, suicide, depression, bipolar disorder, pseudo-seizures, substance use and dependence, and sexual dysfunction. As you know, I have already mentioned psychiatric illness and epilepsy has a bidirectional relationship. That means persons with epilepsy will have high comorbid psychosis or psychiatric illness. Similarly, a patient with psychiatric illness has higher propensity to develop epilepsy. Let's understand what is this generalized anxiety disorder. Just for a moment, think about you had one episode of seizure and think about it. How much anxious will be there? When will be my second episode? Will it occur in front of everyone? When I am driving the vehicle, or when I am swimming, or else when I am walking or climbing any like tree or some places? That means you'll be constantly in worry. That is generalized anxiety disorder, my friends. The commonest is highest prevalence is in anxiety disorder. As you see here, the various studies have clearly said that anxiety disorder prevalence is very high, especially in persons with epilepsy. The maximum is social phobia. Here, a person with epilepsy is worried to go in a social situation. Imagine a lady, she goes into a social situation and she throws a seizure. What will the public will think about her? And she has anxiety and worry, specific phobia, panic disorder, generalized anxiety disorder not otherwise specified, OCD, and PTSD also is very well known. So that means anxiety disorder is the first commonest comorbid condition along with epilepsy. Next, suicide, depression, and epilepsy. This has been studied very well. Suicide is 3 times more frequently in epilepsy than in general population. If you take general population 100 in number, there may not be even a single suicidal death by suicide, but there will be 3 in persons with epilepsy. That means there is a 3 times higher rate of suicide in persons with epilepsy. Number of studies are now suggesting that the relationship between epilepsy and depression is bidirectional. Patients with depression are at increased risk of developing epilepsy by 2.5 times. That means before a person develops epilepsy, he may have early signs and symptoms of depression first, and later, maybe 5 or 6 months down the line, he may develop epilepsy. Further, patients with epilepsy are at increased risk of developing depression. That is, 15 to 25% of the patients with epilepsy has depression. So, what a bidirectional approach. So, please remember this. In a prodromal state kind of thing, the patient may have depressive symptoms, may lasting for 2 to 3 months, and then the patient may develop epilepsy. That is one. Second one is, a person has been already having epilepsy and he may develop depression. That is 15 to 25%. So it's a bidirectional in nature. Let's understand the various meta-analysis has been done. Here, the Kim et al. Studied the meta-analysis of depression in person with epilepsy. Here, 35 studies were included in the meta-analysis. And the total number of persons with epilepsy were 5,434. And they found the point prevalence of depression was estimated around 21%, 21.9%, that is 22%. 22% of persons with epilepsy had depression. And if you look into the bipolar disorder and pseudo-seizures, 10 to 15% of persons with epilepsy also has bipolar disorder. That means he may have mania. Look at the numbers, it is 15%. And approximately 20 to 30% of persons with epilepsy also has pseudo-seizures. Further, substance use and dependence, that is, persons with epilepsy is known to have 15 to 20% of them will have drug abuse, alcohol use, nicotine abuse, or various other things. But relationship between epilepsy and substance use is very complex. And again, it is a bidirectional in nature. I'll be doing a separate video on that. Let's look into this sexual dysfunction in people with epilepsy. The high-risk population who develops sexual dysfunction are uncontrolled epilepsy, longer duration of epilepsy, focal epilepsy, higher frequency, enzyme-inducing drugs are used, and if he has multi-epileptic, anti-epileptic drugs are given. So these are the patients who develop sexual dysfunction. Sexual dysfunction occurs nearly half of the patient, both in men and women. That means by rule, you have to ask sexual dysfunction in persons with epilepsy. Women will generally report of sexual dysfunction in the form of loss of desire, whereas male will have erectile dysfunction or premature ejaculation. So you need to treat persons with epilepsy for sexual dysfunction. And the limited data suggests that newer antiepileptics such as oxcarbazepine, lamotrigine, levetiracetam causes minimal sexual dysfunction. That means these are the drugs which need to be chosen when a patient complains of sexual dysfunction. Epilepsy, medication, depression, anxiety symptoms, substance use, various psychosocial issues also play a role in sexual dysfunction. That means the sexual dysfunction has multiple reasons for sexual dysfunction. That means it is not single factor, not just because a person has epilepsy, not because just he's on anti-epileptic medication. That may be because of depression, it may be because of psychosocial issues, anxiety symptoms, and also interpersonal relationship. All these play a role in sexual dysfunction. But however, I need to discuss about pseudo-seizures, that is, psychogenic non-epileptic episodes. We need to avoid this term, pseudo-seizures, because it is very stigmatizing. That means sometimes you may say it's a pseudo-seizure. That means he is throwing seizures voluntarily or malingering. So it is better to call it as psychogenic non-epileptic episodes. Here, they are characterized by there is no EEG changes or the cortical activity of EEG will be missing, along with bizarre movements. The movements will not be classical of seizures. Further, psychogenic non-epileptic epilepsy can be independent, but one need to be very careful if you are planning to stop the medication. Because, as I mentioned, 30 to 40% of persons with epilepsy will also have psychogenic non-epileptic epilepsy. I will give you an example. A person reported to your clinic, and in the clinic, the history is classical. He had GTCS. Not one, there are many episodes of generalized tonic-clonic seizures are there, well documented. And you have started him on some anti-epileptic medication such as valproate. After 3 months, the patient is brought back by family members, and they say he's taking medicines regularly and having uncontrolled movement, that is uncontrolled epileptic attacks, around 20 to 30 per day. When you are examining, he will throw a non-epileptic episode, that is psychogenic epileptic, and you will be able to induce those episodes also. Now, if you think that he did not have GTCS and you stop the medicine, what will happen? The person will have cluster of attacks or status epilepticus. Why it happens? Imagine whenever there is seizures, the family members give attention to that person. They will make sure that responsibility is not given. The stresses are removed from him. As soon as you start medication, epilepsy vanishes. And now the person is worried about epilepsy. That is one more stress. At the same time, he has been given various other responsibilities. So he is afraid of stopping the medication. But he needs attention from the family member. What will he do? He will have these psychogenic non-epileptic episodes. That means he will have pseudo-seizures. Hence, before deciding to stop any anti-epileptics, ensure he never had epilepsy in the past. Otherwise, you may precipitate status epilepticus. Let's look into the anti-epileptic drug-induced behavioral problems. There are many anti-epileptic drugs which can cause behavioral problems, such as phenobarbital. It is well documented, especially in children. Phenobarbital can cause paradoxical hyperactivity. As soon as you start phenobarbital, the child will become hyperactive, will have decreased attention, decreased concentration, difficulty in studies, and also further, the child may have decline in academic activity. Further, in clobazam, irritability and aggression is known up to 5 to 8%. And drugs like levetiracetam can also cause behavioral abnormalities in the form of psychotic symptoms like delusion and hallucination, suicidal ideation, irritability, and aggressive behavior up to 5 to 10%. And in topiramate, the patient may develop aggression and cognitive deficits. Drugs such as lamotrigine, paramiphenol, vigabatrin, zonisamide, and locosamide also can cause aggression. But however, one need to be very careful before you decide to stop these medicines or else change these medicines. Although seizures can cause all these behavioral problems, also it can cause psychiatric problems, and there is a comorbid psychiatric illness can also occur in seizures. Before you decide and tell that these medicines can cause these symptoms, you have to be very careful, because along with seizures, various other causes may be there. It may be comorbid psychiatric disorder, or else comorbid substance use, or else because of the patient having long duration of hypoxic spells, he may develop cognitive problems, further head injury, and other comorbidities, medical comorbidities also can cause these issues. Hence, before you label a medicine telling that they are causing behavioral problems, be sure and also ascertain before you decide to change the medicine. Moving to the last part, secondary epilepsy, that is infective or autoimmune in nature. There are many epilepsies are seen, especially in infective origin, like meningitis, encephalitis, or various fungal infection, neurocysticercosis can cause seizures, and very well known is herpes simplex virus. In such a scenario, you can also find behavioral problems. Hence, you need to know what is the cause. Sometimes head injury, that is post-traumatic seizures, are also well known. Again, because of the head injury and also because of the seizures, you can see psychiatric comorbidity. Further, The upcoming field is autoimmune disorder like anti-NMDA encephalitis and VGKC encephalitis, limbic encephalitis, and these autoimmune disease also can produce psychiatric symptoms initially and later a classical seizures can be seen. So the causes for epilepsy and neuropsychiatric disorders are multifactorial in origin. And before you discuss about the management, you need to know what are the causes, what is happening. Hence, the first step in management is thorough history taking. Document that and spend time with the patient and the family member to document the classical episode, what is the semiology, whether the person has prodrome, aura, ictal, post-ictal phase, and is there any deficits. Further, ask number of episodes, last episode, how it started, whether he was aware, duration, frequency, bodily injury, time of the episode, where did the episode occur, and also whether there is any dysfunction which it is caused by this epilepsy. And check for organicity, whether there is substance use and epilepsy. Ask for what is the occupation the person is doing, whether he is driving vehicle, whether he is having high risk recreational activities such as scuba diving, maybe swimming. So those kind of activities need to be done under supervision. Check for abnormal behavior history in the past, whether he has psychiatric illness in the past, relationship with abnormal behavior and seizure, whether there is any relation whenever the seizure occurs, abnormal behavior occurs, or whenever there is a seizure, abnormal behavior remits. Check for psychiatric and medical comorbidity. And you need to take a good life chart. This is how the life charting is done. You need to document the seizures. At the same time, you need to document whether there was psychotic episode, whether there was any depressive episode, so that this kind of charting will help you to understand the relationship between the epilepsy and psychiatric comorbidity. Management, if you are able to get a good history, that is more enough. But however, if the history is insufficient, you may have to ask for EEG. You need to look for biochemical investigation, LFT, RFT electrolytes, depending upon whether the patient has come alone, whether you have got a good history, whether you are suspecting any organicity, what kind of medication you are giving, and whether the patient is aged, or else whether the patient has comorbid liver function, dysfunction. Depending upon that, you may also ask for MRI study, hormonal assay, CSF study if you are suspecting any infection, and if you are getting atypical presentation, you may have to consider for immunological study for serum CSF and also serum for Caspar-2, NMDA antibodies, LGI1 and GAD65. These are the antibodies you need to look for both in serum and also CSF. And if you are doubting whether the patient is also has pseudo seizures, then video EEG may be required. Sometimes the patient may have both. He may have epilepsy also and also pseudo seizures. So you have to be very careful before you call for stopping the medication. And if you are suspecting syncope, ECG and echo may have to be done. And especially in autoimmune encephalitis, like limbic encephalitis or NMDA receptor encephalitis, you may have to consider whole body scan or US abdomen scan to rule out paraneoplastic syndrome. And the treatment should be tailored. There is no one fit treatment for epilepsy. Treatment should be individualized according to the type of seizure, depending upon the epilepsy syndrome, whether he is on any co-medication, whether there is any comorbidity, what type of job he is doing, socioeconomic status, individual lifestyle, personal preference, body weight, whether he has any psychiatric comorbidity, and whether the family history of psychosis is there. Whenever you start medication, involve the family members. Especially in developing countries like India, the family members are the one who is going to take care and provide supervision of medication. And further, epilepsy diagnosis needs to be very critically evaluated if the events continue to occur despite optimizing the medication. That means you are given adequate dosage of anti-epileptic drugs, but still he has seizures. You need to review the diagnosis, check whether there is any primary cause, whether there is autoimmune disease, whether there is any space occupying lesion that needs to be done. Hence, there should be a comprehensive plan depending upon the patient's lifestyle and comorbid medical condition. And whenever you treat, first look for the identifying cause, treat the primary cause. If the patient has comorbid psychosis, choose antipsychotics which has less propensity for seizures, such as aripiprazole. If the patient also has mood disorder like mania, choose drugs like valproate and carbamazepine, which acts both on seizure and also as a mood symptom, mood stabilizer. Further, if the patient has depression or anxiety disorder, you may have to consider SSRI such as escitalopram, which has a less drug interaction with the antiepileptics. If the patient has autoimmune encephalitis, you may have to aggressively treat with steroids, immunomodulator, plasmapheresis needs to be considered. Further, if the patient has anxiety disorder, you may have to consider CBT, ERP, behavioral therapy, and psychotherapy. And if the patient has family therapy, or else if the patient has sexual dysfunction, you may have to consider other kind of psychotherapy. Alternate occasional training has to be done. Imagine if a patient has epilepsy and is a driver, it would be advisable to shift the occupation. Hence, occasional training need to be considered. Further, you need to insist for supervised medication and also regular structured review of the number of seizures, medication at least once a year. I would advise at least 6 months once. To conclude, my dear friends, neuropsychiatric comorbidity, especially in epilepsy, is very high. Depending upon the type of epilepsy, depending upon the age of the patients, and various other factors, this neuropsychiatric comorbidity may be very high, from 25% to 60%. The commonest being depression, anxiety, psychosis, cognitive deficits, psychogenic non-epileptic seizures, and many a time these comorbid conditions are undiagnosed and untreated, which adds to the patient's quality of life, burden, and severe loss of quality of life. Hence, you have to be very careful, look for comorbidity. Let me repeat this. Comorbidity is the rule in epilepsy, and you have to understand these neuropsychiatric aspects are because of biological in origin, maybe psychological. There are many social factors which contribute to this comorbid psychiatric conditions. Hence, look for the primary cause. Presence of comorbidity should be checked, and also you need to treat the comorbid condition and be aggressive in management, add psychosocial management. They play a crucial role. Involve the family members. Supervised medication is very essential, and regular follow-up. Thank you very much for giving your valuable time. Stay safe.